In this session on intracranial hemorrhages, we're first going to start by looking at the extradural hemorrhage. This is where there is a rupture of a branch of the middle meningeal artery, usually in the region of the pterion, and the pressure of this arterial bleed lifts the endosteal layer of the dura from the bone on the inside of the skull and produces a hematoma. Because considerable pressure is needed to achieve this, it does mean that there is often a lucid period when the patient seems to recover from the initial blow and then continues with the activity, but usually after a matter of time, which may last as long as an hour, symptoms start to develop. The hematoma puts pressure onto that side of the brain, and the brain is then displaced across to the opposite side, causing several severe problems. For instance, the temporal lobe can be prolapsed under the tentorium cerebelli, and the third nerve can get caught on the edge of the tentorium cerebelli, damaging the parasympathetic fibers within it and giving a dilated pupil on that side. Sometimes the brain is pushed over sufficiently that the cranial nerves on the opposite side can be similarly damaged. The general increase in intracranial pressure usually affects the sixth cranial nerve first, as it runs up the clivus to enter the posterior aspect of the cavernous sinus. Next to be affected is usually the trochlear nerve, the fourth nerve, which gets caught on the edge of the tentorium cerebelli. But it is only the damage of the third nerve that is useful clinically when the patient is unconscious. And that, as we said before, is because we damage the parasympathetic fibers carried in the third nerve, and this will result in a dilated pupil which can become fixed. Studies with CT and MRI show that the hematoma is well rounded because of its arterial pressure and the fact that it's having difficulty in lifting the endosteal dura from the inside of the skull. The shape of the hemorrhage is often referred to as lenticular. The fracture of the pterion can usually be seen on the study, and there is usually soft tissue swelling superficial to the fracture. Note that the midline structures have also been shifted to the opposite side. In order to release the hematoma and hence the intracranial pressure, burr holes must be made, and the surface marking for these are first of all for the anterior branch of the middle meningeal artery. It is 3 centimeters above the midpoint of the zygomatic arch, just inferior to the pterion. For the posterior branch of the middle meningeal artery, we choose a spot where a vertical line from the mastoid process intercepts with a line horizontal from the outer canthus of the eye. Then we move on to a subdural hemorrhage, which is quite different from the extradural hemorrhage. First of all, it is a venous bleed, and the veins that are usually ruptured are the ones that leave the brain and pass into the superior sagittal sinus. The bleeding is in the subdural space between the dura and the arachnoid, and because this is a loose space and because the bleeding is venous, this usually results in a more diffuse and less rounded hematoma than we saw in the extradural hemorrhage. Once again, there can be displacement of the ipsilateral hemisphere towards the other side, and this can get damaged as it passes under the falx cerebri. The temporal lobe can prolapse under the tentorium cerebelli, and again the third cranial nerve can get caught on the edge of the tentorium cerebelli, damaging the parasympathetics and giving a dilated pupil on that side. Sometimes again the displacement of the brain may lead to signs being paradoxically on the opposite side. A cross-section of the superior sagittal sinus shows the arachnoid granulations within it and the cerebral veins draining from the cerebrum into the sinus. This is the usual site of these hemorrhages. CT and MRI studies will show a shift of the midline and the ventricles to the opposite side, and it will show that the hematoma is not rounded as it was in the extradural hemorrhage, but much more diffuse. Herniation of the brain can be in two places. One is the herniation of the temporal lobe through the tentorium cerebelli, and the other is the more classical herniation of the cerebellar tonsil through the foramen magnum. Each of these problems are referred to as coning and may result in significant pressure to the brainstem and damage to the respiratory center. The third hemorrhage is the subarachnoid hemorrhage, where there is a rupture, usually of a small berry aneurysm, on the circle of Willis, which in turn lies within the subarachnoid space. These small berry aneurysms tend to be at the junction of two major vessels. Some 30% are on the anterior cerebral artery, another 30% on the internal carotid, and lesser incidences on the middle cerebral or in the posterior circulation. In years gone by, the only method of dealing with these hemorrhages was via a craniotomy, but now it's possible to deal with these berry aneurysms by endoarterial means. Discussing the problems of subarachnoid hemorrhages gives us a chance to look at the course of the internal carotid artery as it enters the skull. It first enters the carotid canal in the base of the skull and then runs through the petrous temporal bone, both anteriorly and medially, until it reaches the upper limits of the foramen lacerum, where it takes a right angle bend and very soon enters into the cavernous sinus. It then turns at a right angle anteriorly and passes through the cavernous sinus with the abducent nerve on its lateral side, and then takes a right angle at the anterior end of the cavernous sinus and passes up through its roof. Having left the cavernous sinus, it gives off the ophthalmic artery and then takes a right angle bend posteriorly to run along the roof of the cavernous sinus before its final right angle bend to take part in the circle of Willis. At this point, it gives an anterior cerebral artery, a middle cerebral artery, and receives the posterior communicating artery from the posterior circulation. So altogether, we have 6 right angle bends. This is called the carotid siphon and probably plays at least some part in preventing sudden changes of arterial pressure within the skull. We can then look at the various branches of the circle of Willis and see how the two vertebral arteries join to make the basilar artery before completing the circle of Willis. Note the origins of the anterior and posterior spinal artery.